Gutman. I am a surgical oncologist. I have been practicing surgical oncology for melanoma for the last 20 years. I'm a graduate of the postdoctoral fellowship program at MD Anderson Cancer Center in Houston, Texas. Currently, I am Associate Professor of Surgery at Tel Aviv University, Sackler School of Medicine, and practicing physician at the Rabin Medical Center, Petah Tikva. Melanoma is one of the diseases in which early diagnosis is the most important means to cure patients. The thinner the melanoma, the better are the chances for cure. It is easy to diagnose melanoma because it is on the skin, and that's why every patient should be looking at his skin, and every mole or nevus that is changing should be excised immediately for pathology diagnosis. Patients should avoid cryotherapy, shaving, and other procedures which do not give exact pathological examination. Patients should be aware of moles that are changing, and especially in cases where they have been exposed to sun long time and intensively during their childhood. The main means to diagnose melanoma is be aware of the fact that there is a weird mole on the skin or a changing mole on the skin. A patient can consult dermatologist, can undergo dermatological examination, including dermoscopic look, and have these lesions excised properly, completely, and taken for pathology. The current technique for invasive melanomas, especially those that have the potential of spreading out, includes intraoperative lymphatic mapping, excision of the sentinel node biopsy, and wide excision of the melanoma. There are standards for wide excision, and that should be performed as part of the surgery for the melanoma and the sentinel node. Retrieving the sentinel node with the aid of radioisotope scanning and blue dye scanning results in early diagnosis of microscopic disease in the nodes, which enables early surgery, accurate staging, and higher chances for cure. When a patient is about to undergo definitive surgery for melanoma, surgery itself is usually not big one. Surgery includes pre-operative lymphoscintigraphy, which is done at the nuclear medicine unit, and usually the nuclear medicine doctor marks on the skin the location of the sentinel nodes. Then, when the patient is asleep for surgery, we add blue dye, and then we open the lymphatic basins where we expect to find the sentinel nodes. The sentinel nodes are retrieved, taken out for examination, and the basins are closed. Then we pay attention to the primary area of melanoma, where we do wide excision, which should be at least 1 centimeter diameter away from the scar of the biopsy, if the melanoma is up to 1 millimeter thickness. If it's over 1 millimeter thickness, we usually go by 2 centimeter diameter away from the scar. The typical scar of wide local excision will be 8 to 12 centimeters in size. It usually doesn't interfere with regular life, and patient can go on with their life as they used before. The only thing is, if the sentinel nodes are in the axilla, usually the patients will need some physiotherapy to restore full range of motion. Other than that, this particular surgery is not associated with significant disability. According to the results of this surgery, there are two measures that have to be taken. If the sentinel nodes are found to contain melanoma metastasis, then the patient will need to have another surgery, radical excision or radical dissection of the basin involved with melanoma. This is in an attempt at being one step ahead of the disease rather than behind the disease. On the other hand, if the sentinel nodes are negative and do not contain melanoma cells, it means that the risk of the disease coming back is low. Thus, the follow-up should be a bit less extensive, meaning the patient will have to be seen every 4 to 6 months by either surgical oncologist or medical oncologist specializing in melanoma, and that's for the coming 2 years. After that, if the melanoma doesn't come back, every 6 months will be enough for follow-up, and we will include tests like ultrasound, CT, or even PET-CT according to the risk of the disease coming back. From what I see is that in Russia, most patients, or most doctors, when they see a lesion suspicious for melanoma, they don't biopsy it. They just say, well, it is melanoma, and they do wide excision as a primary procedure. In Israel, we never do it. We do excisional biopsy, which takes the melanoma out with very narrow margins, 1 to 2 millimeters. Then we get the pathology results, which should be done by an expert in melanoma pathology, and according to the thickness, we decide upon the wide excision, how much wide, and about the need for sentinel node biopsy. We never decide upon treatment before we got a biopsy approved by an expert melanoma pathologist. Generally speaking, if we take all the melanomas that are considered intermediate thickness, meaning between 1 and 4 millimeters thick, the ratio or the risk of having metastasis in the lymph nodes is about 16%, meaning that 84% of patients will not have metastasis in the lymph nodes, meaning there will be low risk for recurrence. Low risk means not more than 8% in the coming 5 years, let's say. On the other hand, if the nodes are positive, it puts the patients into stage 3 of the disease. Then we recommend risk-reducing therapy, and still the risk of the disease coming back is high, ranges between 30 and 50%. The research perspectives that are active now are trying to get new strategies for what we call neoadjuvant therapy for patients with melanoma at high risk of the disease coming back. These strategies are based on the new medications that came on the market 1.5 years ago, and most of them are biotherapies. All these biotherapies are now under investigation to better identify its role in terms of reducing the risk of the disease coming back after radical surgery.